Okay. Good morning, everybody. We're going to start on that really interesting session now with I'm really looking forward to all this experienced speaker. And the first of them, I'd like to announce Dr. El-Essawi. He will talk about the optimal circuit in all age and comorbidities. Please go ahead.
Thank you very much. It is a delight to be here as always and to share a vision. I've taken the liberty of changing the title, but not the topic. So I'm speaking about MiECC 2024, a decade of experiences, as we are celebrating a decade of this existence of the society. So I'll try not only to elaborate MiECC for which patient, and is it something for a selected patient group or for all patients, but also into the history of the society and about a lot of things that we did right and a few things that we retrospectively could consider some mistakes that we have done. When we sorry. If you look at ERAS, we find that the idea of ERAS, enhanced recovery after surgery, is quite similar to MiECC. It is defined by perspective, enhanced recovery. It's a strategy rather than a single treatment component, and it is a holistic approach towards enhancing physiologic reserves in order to improve outcomes. When we introduced MiECC at the beginning as a concept, we said it's a strategy rather than a machine, and we were heavily criticized because we are told that we are complicating things. We want to spread the message. We want to get the people into the boat, and by calling it a philosophy and a strategy, we are creating some kind of reluctance to adapt the technology. And we were asked, okay, which component of your MiECC system is the important one? Should I leave out the reservoir? Should I leave out the cardiotomy suction? Do I have to do everything at once? And yes, we do have to do everything at once because everything adds to it. And when you come to something like ERAS, nobody questions, is nutritive support important? Is prehabilitation important? Is pain management important? It's all one package with one goal. And MiECC, the goal is a holistic approach towards respecting physiology with preservation of homeostasis as its cornerstone. So actually, we're going into modular systems, we're going into personalized medicine, but however, this all has to have a strategic framework in order not to create chaos. And we try to implement this classification system just to give the readers and the users a way of finding themselves in the world of MiECC. Are we using a type 2 system? Are we using a type 3 system? How do I compare different results from different groups? Could that be related to the type of system that they're using? And one of the problems that we have with this classification, it is an evolutional classification, but it's not a chronologic one. We jumped from type 2 to type 4 before MiECC was even introduced as a terminology. We thought at that sign point that it was minimal invasive, and actually I had a presentation at EACTS in 2010, 2011, where I introduced the mini machine as a minimal invasive concept. And one of the problems we're facing is this nomenclature of type 4. What is a type 4 system? A type 4 system is nothing else than a type 3 system, which gives you the option of introducing a reservoir. And the one thing, there have been two groups that have been very active in type 4 modular systems. That's the group of Professor Nasiades here in Thessaloniki and the group in Braunschweig with my former head of staff, Wolfgang Haringer. And we only made the difference in subclassifying type 4 system either into hybrid system, where you have a reservoir in place, you bypass the reservoir and you just have to open clamps if you're in time of need, or a system where you have quick connectors and in time of need, you can integrate a reservoir into the system. But most of the time, or most of the surgeries are performed with a type 3 system. So it's a reservoir optional system. This is a study from the state of Michigan in 2006 to 2010. They had what they called POCMA, a phase of care mortality analysis. It was a quality improvement tool, and they looked in the state of Michigan over this time period with over 53,000 cases done at causes of death, and they tried to look retrospectively, if we analyze mortality, in which phase of patient care could we have done a difference? And we see that 35% of cases, when they analyzed them, they thought they could have done something else in patient selection or timing of surgery. That gives us a window of opportunity, but as this means that either we have to give the patient another treatment option, a TAVI, a mitral clip, or we have to improve in our surgical performance. And we're mainly focusing on non-modifiable variables. And one of the non-modifiable variables which we are confronted with is patient age. And the idea of respecting physiology and respecting homeostasis is we're preserving physiologic reserves. And these reserves are what the patient needs to overcome the additional burden of surgery. And it's obvious that patients with a good physiological reserves, young patients, low-risk patients, they experience low morbidity, low mortality because they have these reserves. So with the patients of interest that we're focusing on to show an impact of preserving physiology and homeostasis are actually those with depleted reserves, and which are better patients for this group analysis than octogenarians. So we have a large, over the years, we have a large database of patients with which we have implemented MiECC, and we had a look at our octogenarians in which we compared propensity score match 126 patients in each group. Their average age was about 84 years. They had a high Euro score, and we saw that in this patient collective, after propensity score matching, we had a significant difference in 30-day mortality. It dropped from 9.5% to 2.4%. And we saw that we had a significant difference or a significant reduction in post-operative low cardiac output. Again, when we went into more complex surgery, we found that we had 52 patients in two groups, which were again propensity score matched, combined AVR plus CABG. And we saw that the numbers needed to treat are a bit more, although these are lower number of patients, but with mortality differences did not strike significance before 90 days. But this is reasonable. Patients, octogenarians, need more time for rehabilitation, and we will experience mortalities beyond 30 days. And at 90 days, we had statistical difference in mortality between both groups. So is it only an age problem? Or are there other patient collectives that are similarly at high risk? And then we said that patients in end-stage renal disease, patients on dialysis, are a very important patient cohort. Why are they important? Because their numbers are on the rise. Momentarily in Germany, we have about 100,000 patients on dialysis. The numbers are expected to rise by 20 to 25% by the year 2040. And we know that these patients are high-risk patient population with mortality rates, post-operative mortality rates, 30-day mortality rates that are 3 to 4 folds higher than the normal population. This is a publication from Leipzig, one of the biggest centers for cardiac surgery in Germany. And we see that publishing their results in cardiac surgery in patients on dialysis, they had mortality rates of 15% overall, in a population with a Euro score of 8%. But when we go into more complex surgeries, these mortality rates rise even to 30%. So we looked at retrospectively again at our patient population, and we found that between 2006 and 2016, we had operated on 146 dialysis patients. We excluded OPCAPs, reoperations, and MiECC. So we ended up with 60 patients in which we could do a propensity score matching, and we found that there was a high incidence of urgent and emergent procedures amounting to over 50% in the population. We had logistic Euro scores which were beyond 14. And the patients were long on dialysis, much longer than most other published data in that field, and over 30% had combined procedures. And we found that their mortality rate of the overall population was 22%. When we looked at the differences between conventional systems and MiECC, that dropped by over a third, 2/3 actually. And that was statistically significant. And we're speaking about 30-day mortalities. And again, low cardiac output was significantly lower in the MiECC group. When we looked at transfusion rates, we didn't find differences. Why didn't we find differences? In octogenarians, we find differences. But we learned that even octogenarians do not need liberal transfusion strategies. This is something that we have never introduced to dialysis-dependent patients. So we have a liberal transfusion strategy in dialysis-dependent patients. And we looked at the intraoperative data and we found we had significant difference intraoperatively. But once they went to ICU, and I was head of the ICU, so that was my management, I couldn't blame anyone else, we adopted a liberal transfusion strategy and the difference was gone. And most studies that have been performed comparing MiECC to conventional systems that failed to show differences in transfusion either had too low patient numbers or adopted liberal transfusion strategies. All other studies showed significant differences in transfusion. So is it only a solution for high-risk patients? Yes, if we're aiming at mortalities, we have to look at patients with high mortalities. But we cannot ignore that one of the another problem in cardiac surgery is that we have a high rate of morbidities. And if you look at the STS database, and these are data published from 2021, we find that in combined procedures, mitral valve replacement with CABG, we have a major morbidity incidence of 35%. So this gives us another window of opportunity, an opportunity to improve outcomes by reducing adverse events. Again, through preservation of physiologic reserves, respecting physiology, and preserving homeostasis. And this is, COMICS trial has not been published yet, so this is to date the largest prospective randomized trial ever conducted between MiECC and conventional systems. We had published that in 2011, and it was a type 4 system, and it involved 6 centers in Europe, 3 in Germany, 3 outside Germany, 250 patients roughly in each group, simple first-time CABG, AVR, or CABG and AV plus AVR, and these are only the results from Braunschweig. We're the largest center with the highest experience in MiECC, and we had about 80 patients in each group. And one of the things that interested me most is in how many patients do I achieve an optimum outcome? An optimum outcome was defined as no complications and no additional risk through transfusion. We can argue a lot about the drawbacks of transfusion, the negative impact of transfusion on 30-day, on long term, but something that we all have to agree upon, transfusion is a risk, and I don't want to subject my patient to a risk, and I cannot subject my patient to a risk and call it an optimum outcome. So when you look at how often we achieved this optimum outcome, it was 70% in the MiECC cases and 52% in conventional systems, with a significant difference. And if you look at the subgroup analysis just in Braunschweig, you will find that combined procedures, we had more combined procedures, 14% versus 6% in the MiECC group, meaning that MiECC had the capacity to even overcome the additional morbidity of combined procedures. We had statistically significant differences in transfusion requirement, but in low-risk patients, but we had transfusion triggers and all were accounted for the whole, all centers. We had a difference in transfusion rate and in transfusion volume, and we analyzed all that. And in addition, we had significant differences in the incidence of atrial fibrillation. We cut down atrial fibrillation by 30%. And even subsequent multi-centers meta-analysis have all come up with these 30% reduction in postoperative atrial fibrillation. And if we look at in the multivariate analysis at the predictors of this atrial fibrillation, the only modifiable factor was the type of machine used. We can't change the age of the patient or the procedure. And the key to this all is the longevity of extracorporeal circulation. The main difference between minimal invasive from an anatomical perspective and a physiological perspective is with the factor time. The longer that we are on MiECC, the more evident the benefit of MiECC is. For minimal access, this is not true. And we did an analysis in which we looked at roughly 800 patients, elective first-time CABG, who came to the hospital in sinus rhythm. And we looked at the incidence of discharge with atrial fibrillation. So it's not atrial fibrillation within the first 2-3 days and it went away, but we discharged the patients to rehab with atrial fibrillation. And it was significantly less with the MiECC group. And we have the advantage in Germany that all these patients go to the rehab centers. So most 90% of these 700 patients had a Holter monitor within the first 30 postoperative days. And again, the incidence at 30 days was lower in the MiECC group. And if we looked at the predictors of this postoperative atrial fibrillation in the multivariate analysis, the type of circuit played a role and the time on extracorporeal circulation, but only for conventional systems. For the MiECC system, the time on machine did not play a role. I need 2 more minutes and then I'll conclude. One of the problems that we're having in the society is how are we selling our results? We definitely have a marketing problem. As surgeons, we're not convinced that we need to do marketing. However, if we try to propagate a philosophy and we're struggling with that for over this decade, we have to realize that we have a problem. And one of the problems is that we've frequently, and at the beginning of this, introducing this philosophy, we saw it as an alternative to OPCAP. This resulted that even in the largest meta-analysis ever done comparing conventional systems to MiECC to OPCAP, they found that the MiECC system was superior in OPCAP in 5 different variables. But they concluded at the end that MiECC may represent an attractive compromise between OPCAP and conventional systems. So I'm superior, but I'm a compromise. How come? Excellence should be self-driven. We want an optimum outcome for our patient, but we in cardiac surgery are always driven by competition. It is the cardiologists that are improving the results, and then we decide we have to match them. No, we have to improve our quality by our own. So where lies the future of MiECC and the future of cardiac surgery? I hope in an optimum outcome, and I hope through precision medicine, through individualized solutions, through modular systems, we can achieve that. Thank you very much.
Thank you, Afra, for this excellent talk, and congratulations for these results. There's a question from the audience, or if not, I have a short question to you. As I know you always use this RockSafe system from Terumo. Did you make any modification over the years, or did you continue with?
No, actually, we started, our first MiECC system was the one with cardiovention, which Mike mentioned yesterday. It looks like an infusion pump. And this was actually a type 2 system. They had issues with patents for their machine, and they left the market. So one of our perfusionists, Uwe Schönrock, went to Terumo and developed their own MiECC system, and it was a type 4 system from the start, because we could influence directly the introduction of the system and the evolution of the system. So we said we want a modular system with which has components with which we can do valve surgery and which has a safety net, so that we can say, do the system, and if you face any problems, introduce a reservoir, and you're out. We hope that that would help us in propagating the system outside our hospital, because we didn't need the reservoir so often. And so we started directly with the type 4 system.
Now, and I'll announce the next speaker will be Dr.